Here today to talk about whether innovations in cancer treatments matter and how do they matter and what as a patient and family caregiver you should be aware of. We often hear of cases where patients are afraid of a diagnostic test or a treatment based on what happened to an uncle, an aunt, a parent, 15 years ago, 20 years ago. So today we wanted to talk to Dr. Aparna Sreevasta and Dr. Ankur Mittal on how cancer treatments have evolved over time, even diagnostic tests have evolved over time, and how that affects the decisions that you as a cancer patient need to make. Let me quickly introduce Patients Engage as an online platform for patients dealing with chronic diseases and caregivers to share their personal experiences and learn from each other as well as from healthcare professionals. We strongly believe that the more informed people are, the better choices they will make. And the fact that, we are all in this together and we need to support each other. We've always put patients and survivors at the center of all of our content, listened to hundreds of patients and their families over the last few years. And all of our content is driven by our learnings from talking to and listening to patients and caregivers. So this is the second in this series for February, which is focused because of World Cancer Day. The last session we did last week was on key questions to ask on cancer diagnosis. And you can find the recording on our YouTube channel as well, or Facebook channel. Today, as I said, we are very privileged to have with us Dr. Aparna Sreevasta, Consultant Medical Oncologist, Nanjappa Hospitals, Shimoga. We've also got Dr. Ankur Mittal, Consultant Hematologist at Mohandai, Oswal Hospital, Ludhiana. And I'm Aparna Mittal, I'm founder, Patients Engage. Quick reminder that this is supported in public interest by Pfizer. The content of this video is meant for informational and awareness purpose only and is not a substitute for medical advice. So please consult either your doctor or the doctors on this panel here if you are looking for a consultation based on the information you gather here. The views expressed in this video are views of the speaker and not endorsed by either Pfizer or the platform. And you can post your questions on Zoom, Facebook, YouTube. The session will be for about 35 minutes. And if you've not watching this live, you can always send in your questions at editor@patientsengage.com and we will be happy to respond on that. You can follow us on our social media channels, Facebook, Instagram, Twitter, YouTube, and LinkedIn. And you can check out our website, www.patientsengage.com. So let me get started without wasting so much time because we have a lot of questions to ask. So really the focus on today's session is how, innovations have affected cancer treatment over the last 15, 20, 30 years. So let's start with basic question on, how is cancer diagnosed? And I'll just, alternate between the two of you, Dr. Sreevasta and Dr. Ankur. How is cancer diagnosed and detected, and how is that diagnosis changed over time? So let me start with you, Dr. Aparna Sreevasta.
The cancer diagnosis always starts with the patient's story. So we usually listen to what symptoms patient has. So based on the symptoms, we examine the patient and try to see what are the clinical findings that we are getting. Suppose the patient comes with a swelling in the neck. He says that he has a swelling in the neck. Usually examine and see what is there. So whenever there is swelling or bleeding, usually we examine the patient and then we ask for appropriate imaging tests if required, or if the swelling is very easily accessible, if it is easily palpable, we go ahead and take a biopsy. So biopsy is a small piece of the tumor that we take out for examination. So suppose you take the story of 20 years back. So we used to just look at the biopsy under the microscope and see whether it is cancer or not. So that is how we confirm that it is actually cancer. But today we go one step ahead and see if there are any genetic alterations. So cancer is a disease of our genes. Any damage to the genes usually elicit this process of cancer. So today we are going one step ahead and seeing that whether there are any genetic problems that we are encountering, and that is how the cancer journey has changed. That and we are doing imaging more often these days, and we are making the diagnosis at an earlier step compared to yesteryears. So I think that's how we have taken one step ahead, and that's how we diagnose the cancer.
Thank you. Dr. Mittal, any, in terms of the blood cancers, what are the changes in terms of diagnosis?
Yeah, as the science has gradually advanced, and now the patients are more aware of their medical health. So usually they undergo the health checkups, and with those health checkups, sometimes we found the oncology cases earlier at the time of start of the disease only. And secondly, being other medical ailments getting managed better as compared to the other, and as the medical facilities available to the periphery areas also. So the most of the cases they are diagnosed at the start of this. And patients are also aware of their diseases, that are we suffering from something else or not. So getting medical education better day by day. So the diagnosis is getting comparatively easier as compared to if we say about 10 or 20 years back. And secondly, now the patients are also, as they have undergone the medical checkups, now they are aware of their blood counts, they are aware of their hemoglobin values. Being a hematology, most of the patients, they came to us just for the hemoglobin. So that there is a fall in the hemoglobin, what could be the reasons? We need the diagnosis for why the repeatedly we need iron supplements we are already getting in, but still the hemoglobin is low. So these could be the early warning signs of impending malignancies with them. So this is how the time has changed. And as Dr. Aparna well said, with advancements, IHCs, flow cytometry is there. Within 24 hours, we get the answer that what kind of leukemia they are, and we can start the treatment. And IHCs are there, and genetic tests, NGS, now it's available in India at a compassionate cost.
Right. Thank you. So also over time, the treatment options, I mean, I know most people are aware of surgery, chemo, radiation, but can you, both talk about the various types of treatment options that are available for cancer now, and, what is the role of each of the treatment options? So Dr. Aparna, if you can start first.
Yes, actually, if you see the main modalities of treatment, it is usually medical, surgical, and radiation. But over the years, over the last 30 to 50 years, there is a lot of sophistication in the same treatment modalities. For example, if you take surgery, we are doing more, and there is always this fear in patients' mind that the treatment is actually very morbid. The treatment itself can kill the patient. They always have this fear that, if they take radiation, they'll have a lot of complications and they die of the treatment, etc. But today there is a lot of sophistication and they're not that morbid. So suppose you take surgery, we are doing minimally invasive surgeries, we are doing robotic surgeries. So we are not opening the entire abdomen. We are making a small incision and doing a very advanced surgery. And if you take radiation, we are giving very directed, and the 3D planning is in such a way that we hit the cancer hard and we are not causing a lot of side effects. So similarly in medical oncology, if you take, so the word chemo itself really makes the patient very sad, and they get annoyed and they feel very awful to take chemotherapy. But in chemotherapy, we have a lot of medications which prevent the nausea and vomiting. They don't get fever because we are giving growth factors to support their bone marrow. And a lot of chemotherapies are also not causing hair fall also. Many are there which do not cause hair fall. And there is that sophistication. We are having immunotherapy, we are having targeted therapy. So over the years, there is a lot of improvement, refinement in the treatment that we are giving.
Right.
So, yeah.
Right, right. Thank you. And if you can clarify again on chemo, we were talking before we started, is, people see of chemo as one treatment. Can you clarify that as well for the audience? That, the fact there are
Yes.
multiple drugs that may be used.
Chemotherapy is not a single drug, and for that matter, cancer itself is not a single disease. It is nearly 500 different types of cancers that we group them as one cancer. And as you said, the patients will have some bad memories of the uncle dying. We don't know what cancer it was, what stage it was, what treatment was offered 20 years back. So many things are different, and chemo itself is not a single drug, and there are multiple different types of agents, chemicals that are used, and they're totally different. So the patient should always sit and discuss with the oncologist. They should not think, and they think that everything that is prescribed by a oncologist is chemotherapy. No, please ask your doctor, ask for what side effects it will cause. So they should always, there should be an open discussion with your oncologist.
Right, thank you. Dr. Mittal, from your perspective for the blood cancers, what are the treatment options?
Yeah, as we started the discussion that from the previous days, now has the therapy has been changed or not, I would say there is a lot of change in the treatment regimens, treatment protocols, because in hematology we deal with the pediatric groups also and the adult groups also. We are very familiar with the fertility issues which the patient suffering post chemotherapy. Now we have many drugs by which we can preserve the fertility. We can many options which we have which can preserve the fertilities of the patient. And secondly, these chemotherapy drugs, now we have targeted therapies. I generally discuss with the patient when they are worried of chemotherapy. I ask them, have you ever had cough and cold? Have you ever taken an antibiotics? So they said, yes, sir, we have taken antibiotics. As antibiotics works on the infection, similarly, the chemotherapy works on the cancer. So the word is chemotherapy, but it is the treatment. So we have to start with it. So don't get panicked, don't get worried. We are here with you. We generally discuss, I try to spend about 15 to 20 minutes with the patient and the patient family members who are near one, who are going to start the treatment and plan the treatment. I give them all the complications, what we have to do and how the journey will go ahead. And then we plan the treatment according to the patient's need. Now, I think in oncology, we have to give the options to the patient, and the patient has to choose what treatment he has to proceed. We are just there to guide them that these drugs have these side effects and these drugs have these side effects, and this is what we can prolong them. We are here to provide a good quality of life in oncology, in hematology especially. And if we say radiations, yes, now we have the latest machines with us, which have very less side effects. And I have a patient story. This one patient is with me, and his uncle met with an Hodgkin's lymphoma about 30 years back. And the patient has to undergo three surgeries, the three laparotomies, open surgeries at that time. He was treated at abroad in some European state. I will not disclose that. And he has to undergo three surgeries. And if we talk about right now in Hodgkin's lymphoma, just a biopsy followed by chemotherapy just for 6 months. And now we sometimes say the disease is curable. And if persists, it's just a radiation with it. So this is how the treatment has changed over a time.
Right, right. And from the blood cancers perspective, you can also talk a little bit about what are the marrow transplants and stem cell.
Yeah. The patient generally asks us that the transplant is something that is going to trouble them a lot. So this is not the scenario. This is the curative intent. If we want to have a curative intent, that is the transplant is the option. And we have two types, that is autologous and allogenic transplant. Autologous is generally done with the lymphomas and myelomas. And in autologous, we take the patient's stem cells and transfers them back to the patient once they are in complete remission. Whereas in allogenic, we have we have nuclear families, the number of kids are less with the patient. So we have haplotransplants with us in which the donor is not a problem. So mud transplants, full match, and the haplotransplants can be done with in which we ablate the patient's chemotherapy cells and we collect the stem cells from the donor and we transfers to the patients. And the one myth is there that we have number of patients that transplant drop out, those who have financially is not the constraint. the one who is going to donate the stem cells, they are going to have the disease soon. So this is the myth which we have to educate our patient, that donating stem cells will not harm the donor, that will not affect them the whole life. They will not met the disease. They are the saviors of the patients to whom they have donated it.
So in terms of the stem cell donors, is there any data which says how soon they regenerate those stem cells that they have donated?
Stem cells, they keep on dividing in our body. So we don't need to have any data about that. Means they are just regenerating every minute. So there is nothing like that. If we have given a blood transfusion, so within even we don't have calculated that how many hours after that the hemoglobin is back. So it is similarly the same thing. So the stem cells, they keep on regenerating in the body. So
right. Thank you. I think, and we've talked a little bit of this, that people. I think Dr. Sreevasta, you said this, that people often fear the treatment as much as the cancer itself. Can both of you also talk a little bit on how management of these side? I know you mentioned a little bit as well, but if you can stress the fact how management of the side effects of treatment has changed over time. Maybe Dr. Aparna, you can start.
Yes. So as there is sophistication with the treatment, for example, let's take chemotherapy itself. So earlier days, like 10 years back, people used to have a lot of nausea and vomiting, and that used to be very difficult to manage. So people used to admit the patient for 2-3 days so that they can manage the dehydration. But today we are not even admitting the patient, we are giving daycare chemotherapy. So that's how these anti-emetic, the preventive medicines we are giving, so that patients will not develop those dreaded side effects that people are afraid of. So, and usually after taking chemotherapy, the patient's immunity will get altered, and they'll develop low WBC counts, and they'll have bleeding. So we are using growth factors to counteract these side effects. So the patient journey is a lot smoother compared to the yesteryears. And if you take radiation, the planning is such that the side effects are lesser. I'm not saying there are no side effects at all, but the intensity of side effects has definitely reduced. And when we take surgery for that matter, we are doing organ preservation surgeries. For example, in breast cancer, we are just taking out the tumor and not doing the entire breast. So that organ preservation is the mantra of today. So the patient journey is smoother, and the side effects are a lot less compared to the previous generations. And if we take targeted therapy for that matter, we are not having that kind of rampant side effects like chemotherapy. They're more fine-tuned, they kill only the tumor cells, and patients will not have a lot of side effects. So I think today's world is totally different from the previous.
Right. And are there also some of these medications don't require IV, right? They're also just oral drugs.
Subcutaneous, oral also.
Right.
Just given to the skin, so that they don't need IV cannula and lot of things.
Right. Dr. Ankur, do you have anything to add from your perspective on how the management of side effects has changed?
As Dr. Aparna said, very well said, that the nausea and the vomiting and the pain is one which need to be managed we are managing them over here. We have the team with us. It's a full team which works with the oncology, not one department, the other departments, they help us out. And the second thing is in hematology, the patient has to undergo multiple pricks. That is, I would say, that is the other side effect of treatment which the patient has to suffer for investigations, for blood transfusions, for platelets, and catheter related, the cannula related vasculitis and ulcerations. So in our centers, what we have done that we always tell the patient about the PICC lines, that the PICC lines has to be taken, or the ports of the PICC lines. In hemat, we generally go for the PICC lines, but the solids, they go for the ports too. So that makes the family, the patient, easy and a healthy life, especially for the pediatric groups. I would say the children, they forget the treatment in the long run, but they don't forget the pricks which they have to undergo. So the IVSS is one which we have added in recent times.
Right, thank you. And if you can also talk about the role of how, nutrition, exercise, and rehabilitation, as well as counseling has, evolved, and how it supports patients and survivors as well. Dr. Aparna?
Yes, nutrition is a very important and very difficult to tackle in a patient with cancer. Already the patient's nutrition status is debilitated, and with chemotherapy, radiotherapy, they're not able to swallow, they're not able to eat. Their taste is altered. So, and that point of time, the nutritionist and an entire team is required who can actually give lot of time and support the patient, understand their problems, and motivate them. So I think nutrition is a very important aspect, not only during treatment, during the recovery period also. It's very important that they are there has to be some hand holding, and many a times what happens is during the treatment they are always coming to us and we are asking when there is a weight loss. We always push that they should take good nutrition. But during recovery time, when they are coming for follow-up, they feel that they're totally on their own. They feel very sad that some people, they gain weight, some people lose weight, they are not getting enough time. So I think the survivorship is also very important, and they feel totally lost. And usually in the follow-up period, we don't give that much of time to the follow-up patient because they are cured of cancer. They are happily living ever after. So it's very important that we handhold them, and an entire team is required who can give time, because doctors are very busy. So we have to take care, we build a team, and it's very important to delegate these duties to other team members.
Right. Dr. Mittal, in terms of the, for the blood cancers, there are a lot of other concerns that people have on infection, etc., weakness, fatigue. So again, if you can talk a little bit on the role of nutrition and exercise and rehab.
Yeah, means in hematology, the problem arises when the patient is neutropenic, and that is what we need to do with the patient. The patient has to land with the neutropenia, otherwise we will not get the results in hematology. During that neutropenic phase, the patient is very...
Can you just explain neutropenia?
Yeah, true. The neutropenia is the TLC. We all know that the WBC counts are the cells which fights in our body against the infection. Whenever we start with the chemotherapy, as in hematology is a disease of blood. So in that we have to give high dose therapies. These high dose therapies, they affect on the rapidly proliferating cells, which are the cancer cells. But at the same time, they affect on the WBC counts also, and the counts, they fall. So when the TLC, that is in TLC, the neutrophils, when the neutrophil counts are less than 1500, and if it is less than 1000, so we label them the neutropenic patients. And the fever is alarming in those patients. So during that period, so the patient is weak, sometimes they are bedridden. So at the start of treatment, I generally ask the patient, try to move about. I ask them that it is your treatment. So you have to take 4 rounds in the ward in the morning and 4 rounds in the evening. So I will not see you on the bed. I want you sitting around the bed so that you are moving your hands and your legs till the time you can, because that will help the gut motility, passing stools, urination, everything. That helps a lot to the patient, and the myopathies get resolved. So that helps me during the neutropenic phase, because during that the patient is bedridden. So if everything is working fine, so the secretions, the drainage is proper, so the infection rates drops. So the physical exercise is must for the patient as much as he can, but he should not exert during that. And regarding the nutrition, yes, there is a lot of myth with the patients: what to eat, what not to eat, how to eat, from where we can have the foods, especially the sugar. They keep on asking, sir, we have stopped taking sugar because somebody said the sugar causes cancer. It promotes cancer. So we have to tell them the whole genesis in how the PET scan gives us the answer. So it's the PET scan in which the sugar has to be taken, which uptakes. It is not the sugar which promotes the cancer, so you can have it. And secondly, I generally ask them, you can have anything which is home cooked, but it should be free of infections. That is preferably cooked or Tetra packs, so that the infections rates should be less. And the last is the personal hygiene. So in neutropenic patients, the personal hygiene is must. We keep on stressing them the oral gargles, the skin fold care, the genitals care, the anal means the sits bath, how important they are. In case of any rashes or any boil or anything, you have to inform us immediately. Don't be shy. You can tell to any staff of us in case anything develops, so that we can manage them. We can help them out early. So,
right. Thank you. So also over the last few years, the role of palliative care has changed, right? It's no more just end of life care. It's now integrated into the treatment plan. So if you can both talk a little bit about what is palliative care and why patients should discuss that with the doctors and how it is integrated into treatment plan. Dr. Aparna?
Yes, palliative care is a very important part of our patient journey, and especially in India, where we diagnose a lot of majority of our patients are diagnosed in advanced stages, where we are not able to offer them cure, and even the treatment that we give, it gives very short-term improvement in the quality of life. So palliation of symptoms. Okay, we are not able to offer cure to our patient, but at least let's palliate, let's control the symptoms, so that whatever the short span of life the patient has, let that patient live with dignity, and let the patient be comfortable. So palliative care is not always end of life care. Okay, end of life also we try to palliate the symptoms, but from the day one, from the diagnosis, patient will have a lot of pain, and cancer pain. That's one of the worst sort of pain that a person can have. So it is very important to integrate palliative care from day one, so that they get good pain relief, and because of pain they become suicidal and they get depressed. So it's very important to involve the pain specialists and palliative care doctors from the beginning, so that let's make the journey smooth for the patient. And especially end of life, it is a must that we should offer very good pain control. Sometimes some of my patients, they die at home, but they always call me and say that she died very peacefully, that we controlled her pain, she wasn't struggling, she had a very peaceful death. So it's very important that we give importance to palliative care.
Thank you. Thank you, Dr. Aparna. Dr. Mittal, do you want to add anything?
In hematology, the palliation arises when we can't go for the standard lines of chemotherapy, or the patient has a resistant disease which will not respond to our standard line of therapy. So on those patients, we ask for the palliative therapies, and those patients in which we know the cost of therapy is very high and we will not give them much benefit from them, then we'll discuss with the patient families. The spending so much of money will maybe we lose the patient. The chances of losing is high, and at the end you will not have anything if the patient has financial constraints. So sometimes we feel very happy. We have stories with us in which the patient was waiting for the son's marriage or the daughter's marriage, or some work they want to do ahead. So on those cases, the palliative care helps the patient a lot to have a good quality and a peaceful death. Because many of the old age patients, they want to die at home, not they want to spend the whole life and life at hospital. So these things we discuss with the patient. So we want to make them transfusion independent or less of transfusions, pain-free time, so that they can have food or diet at home. We have a palliative care team with us, and they provide home care also to the patients. They help them for the pain management, and they keep on calling them in case of any problem. So palliative care is very important in the oncology.
Right. Thank you. And I think often people don't know the roles of different specialists in cancer as well. So again, if both of you can talk about what are the different specialists that typically a cancer patient would need to be in touch with, right? So they just look at it as, I need to go see an oncologist, but they don't understand the difference between a radiation oncologist, a medical oncologist, a surgical oncologist, a hematologist, etc. And we find that very, very educated people, for instance, don't know hematology, at least. Been very, very surprised on that, but there are these gaps that we often see. So if you can both kind of, for your cancers, talk a little bit on the kind of support teams that people should be prepared to, because they also get confused. Why am I seeing 3 different doctors, etc. Right? So if you can talk a little bit on that. Dr. Aparna first.
Yes, cancer is like an ocean. So it's such a vast, the information is so vast that one person cannot master all those tricks. So we have different specialists who deal with different aspects of cancer. So the oldest is the surgical oncologist. So 2000 years back, any swelling happens, tumor is there, you just cut it and take it out of the body. So that's what a surgeon does. And surgeon, usually these early stage cancers, we operate and take out the tumor. That's a surgical oncologist. Later came this radiation oncologist. Madam Curie, Mary Curie, she discovered this radioactivity, the ionizing radiation, which can kill cancers. So usually, again, both early stage and late stage, advanced stages of cancer, we use radiation, and the doctor who plans this radiation treatment is a radiation oncologist. And the new latest is the medical oncologist. I'm a medical oncologist. So we treat cancers with medications, either tablets or injections. And even if the cancer is widespread all over your body, even then we have magic bullets which can take care of the cancer. So that's why many people think, if when I refer the patient to another doctor, they think that, oh, madam doesn't know something, that's why she's sending. No, it's not that we don't know, but we have dedicated team which can give a very good standard of care. So that's why, and patients often get confused. That madam is telling something, the surgeon is so. You always take a surgical opinion from a surgical oncologist. You take medical oncologist opinion for chemotherapy. So it's very important that we should be aware of whom we are meeting and for what purpose. And usually we do tumor boards where we all sit together, all the 3 doctors, we sit together and we make a plan that what is the sequence of treatment, whether surgery should come first or radiation. Often patients get confused. So to avoid that confusion, we always sit together, all 3 of us, have a tumor board discussion, make the best treatment plan, and we tell the same story to the patient so that they shouldn't get confused. And always when you are getting confused, you take a second opinion. If you feel that you're not understanding something, sometimes the doctor is in a hurry, or maybe they're annoyed because of some other reason, they don't tell you the right thing, you are afraid or you're disappointed, always take a second opinion so that you get a different perspective.
Right. Thank you. Thank you, Dr. Aparna. Dr. Ankur, would you like to add anything?
Yeah, means the hematology is the last branch of the oncology. I would say the hematologists, they deal with the liquid malignancies, that is the blood. So anything which is related to the blood, we deal with that. So there are 3, that is the blood cancers, acute or chronic leukemias or myeloproliferative neoplasms. Next is lymphomas. Lymphomas are the cancers of the nodes. And the last is the multiple myeloma, which sometimes labeled as bone cancer, sometimes labeled as blood cancers, sometimes the kidney failure, means the renal involvement is there. So these are the entities which we deal. And as you very true said, oncology now, it being a comprehensive care, so we need multiple, apart from the oncology departments, we need other departments too, like the nuclear medicine, who reports the PET scans, who can read and guide us better regarding the response rates. We need guided biopsy person, the interventional radiologist, who help us for the biopsies. We need a good laboratory backup for the diagnosis and IHCs, transfusion medicine guy. And other departmentals, whenever we have the complications, to call them cardiology, gastro, and all other departments need to be, they help us a lot during the treatment of the patient to provide them a comprehensive care. And the
Right.
tumor boards are must, yes.
Right. And in addition to this, also remember that there are nutrition specialists, there are physiotherapists, and speech and swallowing therapists, depending on the cancers you have. There are counselors which are trained in, you call them psycho-oncologists as well. So there are palliative care specialists.
I need to add one, Ms. Mittal, that in our institute, like I have given a stat orders to all these departments, that the nutritional, a physiotherapist, a palliative care person, and a psychologist has to see my patients on a regular basis, and they keep on updating me. So what are their family issues which they are going ahead? What are the nutrition issues? And especially sometimes for the kids, our hospital sometimes provide, they are fond of noodles, they are fond of burgers. Sometimes we have to cross the limits. We ask them to give noodles, just boil them with the haldi or salt, no spices in it. Sometimes we have to ask them to get these pakoras and samosas specially made for them without spices. Means
Right.
because they stay us for a long
Correct.
period, about a month in the hospital, which is difficult for everybody.
True. No, and I think it's important to understand that, cancer affects any disease, and, cancer as well affects not just that person, but the family as well. So I think we just need to all be very aware of it. So thank you so much for answering all these questions. Any final words, Dr. Aparna?
Yeah, cancer, just the word itself, don't be biased by the word cancer. Always seek information from the right source. The oncologist, your doctor, is the best person. And don't be shy, don't get disappointed. You discuss with your doctor, and always take it with a positive spirit. And if you have the will to fight, you will always come out triumphant.
Thank you. Dr. Mittal?
I just want to say, yes, it is true that the cancer is not the one person who is suffering, it is the whole family. But that time will not be far when we say that cancer can be treated like diabetes or the hypertension. Just with the medication, with the pill, we can manage these patients. So we should not be afraid of it. We should consult a right person at a right time, get it diagnosed, because the early diagnosis is the mantra to get the better treatment. If we found it at an early stage, go ahead. And don't be afraid of the biopsies. The biopsies is the one which gives us the answer. We can start the treatment. So consult your doctor, family physician, your medical oncologist, your hematologist, diagnose it properly and start the treatment. We are here to help them. We'll always be helping to them.
Thank you. Thank you so much, Dr. Ankur Mittal and Dr. Aparna Sreevasta. As both of them have said, it's important for you to understand the condition, the treatment options, and not fear them. And treatments have changed a lot over the last few decades, so, and continue to evolve. I think cancer is one of the areas where maximum innovation probably has happened. We just wish that there's more in terms of financial innovation, but at least as far as the medical innovation, a lot has happened in the last few decades. So continue to learn more about it when you're diagnosed. Make sure that you get your questions answered, and feel empowered to ask those questions and to be better informed and to not fear. And always reach out to patient leaders as well to understand their experiences. So thank you so much, Dr. Ankur Mittal and Dr. Aparna Sreevasta, for taking the time on a Friday evening to address all of these questions. And once again, we'd like to thank Pfizer for its support as well. Thank you so much.